Hello everyone, welcome to my channel and welcome to my public lecture. And the public lecture topic that I want to share with you in this video is healing before birth, the new era of fetal surgery. Mm. Later, I'm going to share it on screen on whiteboard. Um, so for most of medical history, treatment began after birth. A congenital abnormality was diagnosed, the baby was delivered, and treatment followed. Modern fetal medicine has fundamentally changed this sequence. Today, physicians can sometimes diagnose disease and then assess developmental consequences and then intervene before birth and finally allow the fetus to continue developing. And this represents one of the most extraordinary paradigm shifts in medicine. And the fetus is no longer regarded simply as a passive messenger of pregnancy. In selected circumstances, the fetus is treated as a patient. But fetal surgery creates an extraordinary clinical problem. There are two patients, one uterus, and one shared physiological environment. Any fetal intervention must therefore balance several factors like fetal benefit, maternal safety, gestational age, surgical risk, prematurity risk, and long-term developmental outcome. And this makes fetal surgery one of the most technically demanding and ethically complex areas of modern medicine. So, why do we treat disease before birth? So, this is the question for you to think. And the fundamental principle is simple. Some fetal diseases cause irreversible damage before delivery. If physicians wait until birth, the opportunity to prevent that damage may have already disappeared. Consider fetal lung development. If a congenital condition severely restricts lung growth, waiting until delivery may mean the lungs are permanently underdeveloped. But if fetal therapy can improve the developmental environment while the lungs are still growing, the outcome may be substantially different. This creates a new concept, which is developmental therapeutics. Traditional medicine often repairs an already damaged organ. Fetal medicine sometimes attempts to change the developmental trajectory before permanent damage occurs. Right. So the next part is about the fetus, which is a developing biological system. The fetus is not simply a miniature adult. Fetal physiology is fundamentally different from postnatal physiology. Why? The fetus has a unique cardiovascular system, placental oxygenation, developing lungs, immature kidneys, developing immune function, rapidly changing neurological systems, constantly changing metabolic requirements. So fetal surgery requires knowledge of these things. Okay, let me share it on the screen. Uh, so these things. So this is fetal surgery requires this knowledge. Embryology plus developmental biology plus maternal physiology plus fetal physiology plus surgery plus imaging plus neonatology. Yeah. So this multidisciplinary integration is what makes fetal medicine unique. Now let's talk about the placenta, which is the central interface. So to understand fetal surgery, we must understand the placenta. The placenta regulates the exchange of oxygen, carbon dioxide, glucose, amino acids, lipids, hormones, waste products. It also participates in immune regulation, endocrine signaling, fetal growth, maternal adaptation. So the fetus cannot be treated independently of the placenta. In some fetal diseases, the placenta itself becomes part of the therapeutic target. And this is particularly crucial in complicated twin pregnancies. Now, in this part, let me share the three major forms of fetal intervention. And the first one is open fetal surgery. Okay. Fetal procedures can broadly be divided into three categories. So these are three major forms. So as in first one, the uterus is surgically opened and the fetus is partially exposed. And this provides the right access but creates significant maternal and obstetric risk. Open fetal surgery is so reserved for highly selected conditions. And the second one is fetoscopic surgery or fetoscopic surgery. A small camera and specialized instruments are introduced through tiny openings. Advantages include smaller incisions and less uterine disruptions, direct visualization, and reduced maternal surgical trauma compared with open approaches. So, fetoscopy has become particularly important in placental and airway procedures. And the next one is percutaneous, percutaneous image-guided procedure. A needle or catheter is introduced through the maternal abdomen under ultrasound guide. And this may allow fetal transfusion, fluid drainage, and balloon placement and cardiac interventions, other targeted procedures. And this progression is remarkable. So it's like open surgery and then minimally invasive surgery and then image-guided microsurgery. Now, the next part, I want to talk about fetal spina bifida surgery. One of the best-known advances in fetal surgery involves myoluminin gazelle. Yeah, so I'm going to write it down, this word here. So myoluminin gazelle, a severe form of spina bifida. The spinal cord is exposed since the vertebral structures fail to close properly. Traditionally, surgeons repair the defect after birth, but the problem is that neurological injury may occur during fetal development, not simply at delivery. And this led researchers to ask, could repairing the spinal lesion before birth reduce progressive damage? And the landmark management of myoluminin gazelle study, MOMS, demonstrated important benefits of prenatal surgery in carefully selected patients, including reduced need for cerebrospinal fluid, shunting, and improved motor outcomes compared with postnatal repair alone. And this changed the field. The goal was no longer simply repair the defect. It became prevent additional neurological damage while development is still occurring. Now, one of the most sophisticated areas of fetal surgery involves monochorionic, yeah, monochorionic twin pregnancies. Let me write it down. This one. This one is monochro, yeah, monochorionic twin pregnancies. When twins share a placenta, abnormal vascular connections can develop between their circulations. This can produce twin-to-twin transfusion syndrome, which is also called as 3DS, yeah, triple DS. One twin becomes the donor, while the other becomes the recipient. The donor may develop severe reduced blood volume and poor growth. The recipient may develop excessive blood volume and cardiac strain. And the problem is not simply inside either fetus. The problem is in the shared placental circulation. Right, the next topic, the next one I want to share with you is fetoscopic laser surgery. In selected cases, surgeons can perform fetoscopic laser photocoagulation. Yeah, a tiny fetoscope is introduced into the uterus. The surgeon identifies abnormal placental vascular connections. Laser energy is then used to close these communicating vessels. And this changes the circulation between the twins. And think about what is happening. The surgeon is not simply repairing a baby. The surgeon is re-engineering the fetal environment. And this is one of the most remarkable examples of modern developmental medicine. Okay, the next one is fetal anemia and intrauterine transfusion. Another major achievement is treatment of severe fetal anemia. One cause can be maternal fetal blood group incompatibility. Um, One cause can be, yeah, maternal fetal blood group incompatibility, particularly severe Rh alloimmunization. If fetal anemia becomes severe, complications can include high output cardiac failure, hydrops, fetal death. Under ultrasound guidance, specialists can assess the fetal circulation and provide an intrauterine transfusion, right? So in other words, blood transfusion can occur before birth. And this is an extraordinary example of the fetus being treated as an independent patient. Right. So the next part is fetal airway and lung development. Now consider severe congenital diaphragmatic hernia or CDH. Okay. Let me write it down, that word for you. In several cases, abdominal abdominal organs moved into the chest and interfere with normal lung development. The problem is not simply that the diaphragm is abnormal. The major threat may be insufficient lung development. One fetal therapy used in selected severe cases is fetoscopic endoluminal tracheal occlusion, fetal. Yeah, so that is the one fetal therapy used in the selected severe cases, but not all cases, only severe cases. That's called fetal. A small balloon temporarily blocks the fetal trachea. Yeah, trachea. Why would blocking the airway help? Fetal lungs naturally produce fluid. Temporary occlusion can increase pressure within the developing lungs and promote lung growth, and the balloon is subsequently removed. This illustrates a fundamental principle of fetal medicine. Sometimes the objective is not to repair the abnormality directly, but to modify the environment so the organ can develop better. Right. The next one is fetal cardiac intervention. Well, the fetal heart begins functioning remarkably early in development. Certain sorry, um, some or certain congenital heart conditions involve severe obstruction of blood flow through developing cardiac structures. In highly specialized circumstances, fetal cardiac interventions can use a needle and catheter to cross an obstructed valve and open it with balloon dilation. And the objective is developmental, and the goal is not simply to make blood flow better today. It may be to improve blood flow and encourage better ventricular development and potentially change the severity of heart disease after birth. So this is developmental cardiology at its most sophisticated. Now let's talk about fetal tumors. Some fetal tumors can become life-threatening since they place enormous demands on the fetal cardiovascular system. A highly vascular tumor may require substantial blood flow. The fetal heart must compensate by increasing cardiac output. Eventually, heart failure and heart drops may develop. In exceptionally selected situations, fetal intervention may be considered. Again, the objective is often broader than simply removing the tumor. The physician is attempting to prevent tumor growth, and then cardiovascular overload, and then fetal heart failure, and then fetal death. So, in this part, let me talk about the technology behind fetal surgery. Well, modern fetal surgery depends on technological convergence, right? Um, right now, we have real-time visualization of fetal anatomy, placental anatomy, blood vessels, blood flow, needles, and surgical instruments. And droplet imaging, which allows clinicians to evaluate fetal and placental circulation. And the next one is fetoscopy. Miniaturized cameras allow surgeons to visualize structures within the uterus, and laser technology allow targeted treatment of abnormal placental vessels, and catheter technology, which allows interventions through extremely small access roads. And the future may incorporate robotic systems capable of trauma reduction, greater precision, microsurgical manipulation, automated positioning. And artificial intelligence could become an paramount component of fetal intervention. AI may assist with image interpretation, such as detecting subtle abnormalities on ultrasound or MRI, and anatomical mapping, which identifies placental vessels, fetal organs, surgical targets, and estimating fetal survivor, prematurity risk, maternal complications, post-operative outcomes, potentially helping physicians determine the safest trajectory for needles and instruments. The ultimate goal is not autonomous surgery, it is human expertise amplified by computational intelligence. Now, in this part, it's coming to a closing of my lecture, but this is also this is intriguing. Digital twins and fetal surgery. This is where fetal surgery intersects with the emergent field of digital twin pregnancy. Imagine a computational model containing maternal physiology, placental blood flow, fetal circulation, fetal anatomy, genetic information, ultrasound data, and growth trajectory. So before operating, clinicians could theoretically simulate different interventions. So I'm going to write it down here, different interventions. It's from option 1 to option 4 here. Okay, I'm going to erase all these here. So these are from options 1 to option 4. So this model could estimate the likely consequences of each pathway, and this could transform fetal medicine from diagnosis and additionally included clinical intuition toward diagnosis and then simulation and then personalized prediction and clinical judgment. Right. One of the deepest concepts in fetal therapy is the developmental window. Yeah. Fetal therapy, one of the important thing in fetal development, crucial. It's developmental window. There may be a period when intervention can produce maximum benefits, or if it is early, the procedure itself may cause unacceptable harm. If it is too late, irreversible developmental injury may already have occurred. So timing becomes a therapeutic variable. So the physician must determine what should be treated, when should it be treated, how should it be treated, how much intervention is necessary. So this requires an understanding of developmental biology, not merely surgical anatomy. Right. So, and they might also include maternal and fetal ethical problem. Fetal surgery creates unusual ethical situations. There are two patients, the mother experiences the procedural risk, and the FedEx receives the potential benefit, and the interests of both must be considered. For instance, a procedure may offer substantial fetal benefit, increase the mother's risk of premature delivery, uterine complications, surgical complications, future pregnancy risk. So, fetal benefit cannot automatically override maternal autonomy and safety. And the ethical foundation also must include informed consent, maternal autonomy, evidence-based medicine, proportionality of risk and benefit, multidisciplinary decision making. Right. So, um, the fetal surgery represents more than a new surgical technique. It represents a fundamental change in how medicine understands disease. So the fetus is not simply waiting to become a patient. In carefully selected circumstances, the fetus um, is already a patient. And the uterus is not simply a container, it is a highly complex developmental environment. And the placenta is not simply a connection, it is a sophisticated biological interface. And pregnancy is not simply a waiting period, it is a therapeutic window. So the new era of fetal surgery is moving medicines from repairing disease after birth toward preventing developmental damage before birth. So we can now repair certain fetal abnormalities, modify placental circulation, treat fetal anemia, support fetal lung development, intervene in selected cardiac conditions, and use increasingly sophisticated imaging and minimally invasive technology. And the next frontier may involve AI plus digital twins plus robotics plus gene therapy plus regenerative medicine. But the ultimate measure of success should never be technological sophistication alone. And the goal is a healthier mother, a healthier child, and a better lifetime outcome. And the future of fetal medicine will depend on bringing together three disciplines: biology, technology, and wisdom. Biology means understanding how the fetus develops, and technology, as in giving physicians increasingly precise ways to intervene, and wisdom, knowing when intervention is justified and how to protect both mother and child. And the greatest revolution may ultimately be this: medicine will no longer simply wait for a baby to be born before beginning to heal. It will increasingly ask whether we can protect development, prevent injury, and change the trajectory of disease while the life is still forming. So this is a promise, the profound responsibility of the new era of fetal surgery. Well, I hope you learned something out of it. And I'll see you in my next lecture with more intriguing topics. God bless you and have a lovely day ahead. Goodbye.